Hello class. We will be presenting on varicella, also known as the chickenpox, for our epidemiology and population health course. We hope you were able to watch the videos prior to viewing this presentation, and our discussion post is also up on Canvas. After reviewing this presentation, learners should expect to take away signs and symptoms of varicella in order to properly diagnose the infectious disease and to be able to educate patients on levels of prevention for the infectious disease, varicella. Learners can also expect to have a comprehensive picture of the epidemiology of varicella zoster virus and understand the modifiable risk factors for varicella. Furthermore, the learners will have a better understanding of the incidence, prevalence, and mortality rates that are associated with varicella. Varicella, or the chickenpox, is a highly contagious and acute disease that is caused by the varicella zoster virus. Anyone that hasn't received the varicella vaccine or hasn't had the chickenpox illness is at risk of developing the chickenpox. Additionally, those who have had the chickenpox illness previously are at risk of developing shingles or herpes zoster virus. In 1995, the U.S. approved licensure for the varicella vaccine, and since then, the incidence, the prevalence, mortality, and morbidity rates have drastically declined. Signs and symptoms of the chickenpox typically appear 10 to 28 days post-exposure to the varicella virus and typically last anywhere from 5 to 10 days. The rash has become the primary symptom of diagnosis of patients with chickenpox. According to the CDC, the rash will appear first on the stomach, back, and face, and then spread to the entire body, causing anywhere from 250 to 500 blisters. Prior to the rash developing, patients may develop a fever, headache, tiredness, or lack of appetite. It is possible to have all three phases of the rash present at one time due to new lesions appearing for the first several days. It is important to remind patients that they can spread the virus for up to 48 hours prior to the rash appearing. Another important point to discuss with patients is that once infected, they will remain contagious to others until all of the open spots crust over. It usually will take 1 week for all of the blisters to become scabs. Listed as an infectious disease objective in Healthy People 2020 from the Office of Disease Prevention and Health Promotion, reducing the incidence of varicella is a national goal. Listed interventions to reach this goal are to increase the amount of children who receive the first dose of varicella vaccine by 19 to 35 months of age, and also to increase the amount of children who receive the second dose of varicella vaccine by age 13 to 15 years. By searching using Google Scholar, we are able to find many recent studies available regarding varicella, in addition to current clinical guidelines. We found many epidemiological studies, which we will discuss on a further slide. Also, the CDC has the vaccine schedule and provider and patient information. And also listed on up-to-date are clinical guidelines regarding prevention and treatment guidelines of varicella. Marin, Zhang, and Seward found a mortality decline of 88% since the implementation of one-dose vaccine program in the U.S. by calculating the age-adjusted and age-specific mortality rates between the years 2002 and 2007. They hypothesized that the two-dose vaccine series may prevent severe outcomes from varicella infection. Shapiro et al. Published in 2011 used a case control study to identify that the odds of developing varicella were 95% lower for children who had received 2 doses of varicella vaccine compared to the previously recommended 1-dose vaccine. Baxter et al. In 2014 conducted a series of 5 cross-sectional studies. By using a telephone survey from more than 8,000 participants, they were able to conclude that there was a major reduction in the incidence and hospitalization of varicella during the 15 years of the varicella vaccine program. They also did not see any evidence of a shift to the burden of varicella to older age groups as they thought may occur. Baxter et al. Published in 2013 prospectively followed roughly 8,000 children who were vaccinated with varicella vaccine during the 1995 initiation. Roughly 3,000 participants also received a second dose of vaccine. Their study found that one dose of vaccine decreased the incidence of varicella dramatically, and that the varicella vaccine may reduce the risk of shingles in vaccinated children. Shaw et al., published in 2010, compared varicella-related hospital discharges pre- and post-implementation of the varicella vaccine series. They found statistically significant decreases in the amount of varicella-related discharges after the implementation of vaccine. Using a case control method, Glanz et al., published in 2010, found a significant increase in risk of complications in children whose parents refused vaccinating against varicella. The CDC published a case report in 2013 of a varicella-related death of an unvaccinated, previously healthy adolescent. This patient had received other suggested childhood vaccines, however, refused the varicella vaccine. She was admitted with a diagnosis of septic shock and died on day 21 of hospitalization due to varicella-related complications. Klein et al., published in 2007, aimed to determine the wide range in antibody titers after varicella immunization. The study compared post-immunization antibody titers among 248 biological siblings and comparing the pairs of siblings to all possible unrelated non-sibling pairs created. This study concluded that there is a genetic component to the response to varicella vaccine based on the siblings' responses to the vaccination. According to the CDC, prior to the U.S. vaccination program of chickenpox in 1995, the illness caused more than 100 deaths per year. After the start of the vaccination program, deaths due to chickenpox decreased by 90%, meaning fewer than 20 people die from chickenpox each year. Prior to 1995, chickenpox caused more than 10,000 hospitalizations each year. But since 1995, there are 84% fewer hospitalizations, meaning fewer than 1,700 people are hospitalized each year for the chickenpox. Prior to the initiation of the vaccination program, there were more than 4 million individuals diagnosed with chickenpox per year. Since the introduction of the varicella vaccine, there have been 92% fewer cases of the chickenpox, or fewer than 350,000 people diagnosed with chickenpox each year. Listed as an objective for Healthy People 2020, varicella is a vaccine-preventable illness, often occurring during childhood, that causes rash, fever, fatigue, and has the potential to carry very serious risks to the patient's health. According to UpToDate, risks and complications of varicella include soft tissue infection, pneumonia, hepatitis, and encephalitis. At-risk groups include adults, pregnant women, and immunocompromised individuals. Our problem statement is that despite recommended and available varicella vaccines, some patients and their families opt out of vaccination, posing a risk to themselves and others around them. In addition, outbreaks and deaths continue to occur as a result of complications from varicella. A clinical description obtained from UpToDate is varicella illness caused by varicella zoster virus, begins with a prodrome of fever, malaise, decreased appetite, and or pharyngitis, followed by the development of a pruritic vesicular rash. The case definition, taken directly from the CDC, is that varicella is an illness with acute onset of generalized maculopapulovesicular rash without other apparent cause. Breakthrough disease is development of varicella in a vaccinated person. In this case, the disease is usually mild, with fewer than 50 skin lesions and a shorter duration of illness. The rash may also be atypical in appearance, maculopapular, with few or no vesicles. According to the CDC, a case of varicella is classified as probable if the patient meets the clinical case definition but is not clinically confirmed to have varicella or be linked to a confirmed case of varicella. A case is confirmed via laboratory testing or is linked to a confirmed case of varicella. To note, 2 probable cases that are epidemiologically linked are considered confirmed, even in the absence of laboratory confirmation. Varicella infection can occur at any age. However, the most serious infections occur in infants, the elderly, and immunocompromised individuals. School-age children are the most susceptible due to their close interaction with other children. Varicella is highly contagious and can be spread through airborne droplets or direct contact with the lesion fluids. Transmission can occur in any area with close contact, including daycares, schools, and hospitals. According to a publication by Gilchrist, incidence of varicella tends to rise in the spring each year. Determinants of health and disparities that are likely to impact the incidence of varicella are access to health care, social norms, genetics and immune responses, personal beliefs, socioeconomic status, policies regarding vaccine requirements, the inability to receive vaccines, and attending places of exposure risk. Resolution of the symptoms of varicella illness results in a latent infection of the virus, which can present as herpes zosters or shingles, a painful unilateral vesicular rash of the dermatomes, occurring later in life. This occurs because the virus stays dormant in the dorsal root ganglia and becomes reactivated. Risk factors of developing shingles include age, trauma, malignancy, chronic lung disease, chronic kidney disease, and disorders of the immunity. Additionally, a person who does not have immunity to varicella can develop varicella infection from interaction with a person with shingles. There is a genetic component to the development of varicella illness, as a sibling cohort study by Klein et al. Supports that immune response to varicella vaccine has a genetic component based on titer levels. Unvaccinated people, due to personal beliefs or inability to receive the varicella vaccine, are at risk for developing the pruritic rash and associated symptoms of varicella, in addition to complications and secondary infections. Additionally, many healthy adult deaths are the result of contracting varicella from their unvaccinated children. Varicella outbreaks continue to occur in schools. The CDC reports 6 states of having outbreaks between the years of 2005 to 2012. However, the 2-dose vaccine series is decreasing the severity of these outbreaks. Death from varicella can occur in the elderly and other high-risk individuals, but also occurs in healthy individuals. There is a risk for an epidemic of varicella if parents continue to not vaccinate their children. There is no national requirement regarding varicella surveillance. However, each state health department may have their own procedures for tracking the illness. The CDC provides guidelines for local and state health departments to investigate and report outbreaks. This is called the National Center for Immunization and Respiratory Diseases. Additionally, states are encouraged to report cases to the National Notifiable Disease Surveillance System. Created to monitor the impact of the varicella vaccine specifically is the Varicella Active Surveillance Project. In addition, the CDC is tracking the epidemiology of herpes zosters or shingles in relation to the varicella vaccine. However, no relationship between the two has yet to be determined. Varicella can be clinically diagnosed based on a physical exam if the patient presents with fever, fatigue, itching rash that develops into crusted lesions. Because the incidence of varicella is decreasing, many providers may choose lab testing to diagnose varicella. According to the CDC, lab criteria for diagnosis includes one of the following: a varicella zosters virus detected on specimen, a detection of varicella DNA by PCR or DFA from specimen, this is the method of choice, or an increase in varicella IgG titer by 4 times or greater. Lab testing is recommended by the CDC for confirming an outbreak, a cause of death, determining susceptibility to varicella, or to investigate vaccine-related adverse events. There is a national varicella zosters virus lab, which provides services to states for confirmation of varicella and for research purposes. Here's our web of causation for varicella. First, there needs to be a susceptible host. Infants through young adults are at the highest risk, and they need to have an exposure to varicella, which is often spread through respiratory tract, coughing and sneezing, in addition to touching of the lesions. There's an incubation period of 4 to 16 days after exposure, and a prodrome may develop of 1 to 2 days before the rash develops. After the prodrome, the patient presents with a blister-like rash, itching, tiredness, and fatigue. And the patient is infectious until all lesions are crusted, which is typically 4 to 7 days from the rash onset. This web could be stopped or symptoms lessened if the susceptible host were vaccinated against varicella at the recommended times. And we will go over the vaccine schedule for varicella in later slides. Vaccinated children may still get the chickenpox, but the symptoms will not be as bad and will more than likely not require hospitalization.
Slide 18, Preventative Measures. Primary prevention occurs during the period of pre-pathogenesis and is focused on health promotion and specific protection against varicella. This is based on Friss and Sellers, 2014. An example of primary prevention includes vaccination against varicella. The CDC in 2016 recommends 2 doses of the chickenpox vaccine, with the first dose given between 12 to 15 months of age and the second dose given between 4 to 6 years of age. Secondary prevention occurs during the pathogenesis phase of the disease and encompasses early diagnosis as well as prompt treatment and disability limitation. This is from Friss and Sellers, 2014. The goal of secondary prevention is to reduce the number of exposures that progress into chickenpox. Common interventions may include prophylactic administration of the chickenpox vaccine and antiviral medications such as acyclovir within the first 24 hours of symptom onset and isolation. Tertiary prevention takes place during late pathogenesis and disease has already occurred and been clinically treated. This is based on Friss and Sellers in 2014. Another goal of the tertiary prevention is to limit any permanent complications or disabilities that may potentially occur. During tertiary prevention, continued use of medications such as antivirals are the main interventions for varicella. Slide 19, Modifiable Risk Factors. Common modifiable risk factors for varicella include close contact with someone diagnosed with chickenpox, frequent traveling outside of the United States, and career settings that increase chances for exposure. Typically, healthcare and schools or daycares would be included in this population. And plans for addressing modifiable risk factors would include identifying individuals at increased risk or that have been exposed to varicella. This typically will be including children. And it would also include identifying individuals appropriate for the varicella vaccination. It is important to be able to discuss with parents that are hesitant to vaccinate their child. As stated in previous slides, it will be important as healthcare providers to be able to have an open communication with patients and parents regarding vaccinations. According to Hendricks, Sturm, Zimet, and Meslin, 2016, although it is difficult to provide education to parents that are vaccine hesitant and vaccine opposing, one approach to investigate further would be presenting parents with information demonstrating signs and symptoms that a child would typically experience if they contracted a vaccine-preventable illness. Although this seems extreme, as healthcare providers, it will be important that we remain invested and not dismiss parents that are against vaccinations, but rather educate. Slide 20, Treatment Options. First, immunizations will be discussed. There are 2 varicella vaccinations that have been approved for use in the United States. The first is the varicella vaccine, which is also known as Varivax. According to the CDC in 2016, the United States first licensed the use of Varivax in 1995. The CDC recommends that children receive a routine initial vaccination dose between the ages of 12 to 15 months, followed by a second vaccination that is to take place between 4 to 6 years of age. There should be at least 3 months in between the first and second dose for children younger than 13 years of age. The CDC also recommends that adolescents aged 13 and older and adults without any evidence of immunity to the varicella virus be vaccinated with Varivax. Adolescents and adults should receive 2 doses at least 4 weeks apart. The second vaccine is the measles, mumps, rubella, varicella, or MMRV vaccination. This is also known as ProQuad. In 2016, the CDC reported the FDA approval of the MMRV vaccine for use in patients 12 months of age and up to 12 years of age. Patients that are age 13 or older should not receive the MMRV vaccine. The MMRV vaccine can be given for both the first and second doses of both MMR and varicella vaccinations. However, there must be a minimum of 3 months in between the first and second doses. Although the United States vaccination program and licensure of the one-dose varicella vaccine resulted in a drastic decline in morbidity and mortality due to varicella, further varicella surveillance indicated a plateau of varicella cases in the early 2000s, according to the CDC. Upon further investigation, it was determined that this was the result of breakthrough varicella infections. A study by Shapiro, Vasquez, Esposito, Holabird, Steinberg, Dezira, LaRussa, and Gershon in 2011 looked at the effectiveness of the one-dose vaccine compared to the two-dose vaccine. They determined that the matched odds ratio for 2 doses versus 1 dose of the vaccine was 0.053, indicating that in the first 2.5 years after introduction of the second dose, the odds of developing varicella for children who had received 2 doses of the varicella vaccine were 95% lower than for those who had only received 1 dose. This study finding demonstrates the importance of the 2006 recommendation for the 2-dose varicella vaccination, according to the CDC. Slide 21, Treatment Options Continued. In 2016, the CDC recommended the use of varicella vaccine post-exposure prophylaxis for unvaccinated individuals older than 12 months of age and without any prior evidence of immunity. The vaccine should be given as soon as possible after post-exposure and within 5 days after initial exposure to the rash, according to the CDC. The varicella vaccine post-exposure vaccination has been proven to be 70 to 100% effective in individuals that receive it within 3 days of exposure, and may be effective up to 5 days of exposure. Although it is less effective if given more than 5 days after exposure, it has been shown to produce immunity to varicella as long as the patient is not infected with varicella during the time of vaccination. The CDC has also recommended that the varicella-zoster immune globulin, also known as Varizig, be administered to individuals at risk of developing varicella and that have contraindications to the varicella vaccine and were recently exposed to the virus. Examples of individuals appropriate for this treatment include immunocompromised patients, pregnant patients, and some infants. The varicella-zoster immune globulin should be given as soon as possible after exposure, and according to the CDC 2016, the varicella-zoster immune globulin has been proven to be effective as late as 10 days after exposure. Slide 22, Treatment Options Continued. According to Albrecht 2016, antivirals such as acyclovir are recommended for patients at risk of complications, such as those individuals that have not been vaccinated, pregnant patients, and immunocompromised patients. Antiviral therapies have been shown to help reduce the symptom severity and limit complications, according to Albrecht in 2016. Supportive care typically will include the use of antihistamines to help with severe pruritus. Acetaminophen can be used for febrile patients, especially in children. However, children should not be given salicylates due to the risk of developing Reye's syndrome, according to Albrecht 2016. Contact and airborne isolation are typically initiated for patients that are hospitalized with chickenpox. Slide 23, Barriers to Implementing Treatment. In this slide, the main focus will be on legal and ethical barriers that often are encountered for parents and the refusal of vaccinations. According to Hendricks, Sturm, Zimet, and Meslin in 2016, some parents invoke the herd immunity argument as a reason for not immunizing their children. Parents that feel this way base their argument on the fact that since other children are already vaccinated, preventing the spread of any other illness, then why should they risk exposure of their child to these possible side effects from immunizations, such as autism, which has been highly debated as of late. Although all states have laws requiring vaccination prior to school entry, there are numerous states that have non-medical exemptions to such laws. According to the Wisconsin Department of Health Services in 2016, the Wisconsin student immunization requirements can be waived for personal conviction, religious or medical or health reasons, and this can be found on page 8. Although it is also stated in this document that if an outbreak does take place, the child would not be allowed to come to school if they are not immunized. However, this demonstrates the concern for states with such exemption policies. In the event that an outbreak would occur, children that were not vaccinated would be at a higher risk of developing this potentially fatal disease. Slide 24, Theory-Based Varicella Treatment. The health belief model was chosen based on its preventative health approach, which can easily be applied to varicella. According to Jones, Jensen, Schur, Brown, Christie, and Weaver in 2015, the health belief model is based on 6 constructs that predict health behavior, and these include risk susceptibility, benefits to action, barriers to action, self-efficacy, risk severity, and cues to action. Specifically, the health belief model appeals and applies to varicella in terms of vaccinations against the virus. According to Jones et al. In 2015 on page 3, the health belief model posits that people will take action to prevent illness if they regard themselves as susceptible to a condition, otherwise thought to be perceived susceptibility, and if they believe it would have a potential serious consequence, also known as perceived severity. This model could be used to further research varicella vaccination, and if perceived susceptibility and perceived severity would influence parents that are against vaccinating their children. Slide 25, Policy and Regulation Changes. Currently, the American Academy of Pediatrics 2017 recommends that all state laws that allow non-medical exemptions for school immunization entry requirements be eliminated throughout the United States. According to the American Academy of Pediatrics in 2017, there are currently 16 states that allow personal belief exemptions for school entry immunization requirements. We propose that legislation be changed requiring all states to eliminate state laws that permit non-medical exemptions for school immunization requirements. As healthcare providers, it will be important that we participate in local councils and organizations to bring forth immunization concerns to the state legislation. Changes to legislation at the state level are necessary in order to address the barriers discussed in the previous slides.
The CDC provides a comprehensive explanation of varicella for both providers and patients. Included on their website are clinical signs and symptoms of varicella, epidemiology of the virus, and vaccine information. UpToDate also provides guidelines on the diagnosis, treatment, and vaccination of varicella and is updated as new information is provided. There are numerous quality epidemiological and experimental studies that have been sparked by the 1995 introduction of varicella vaccine and the addition of the second vaccine to the series. To summarize our findings, in 1995, the varicella vaccine was introduced as a one-dose vaccine. Prior to the vaccine, 4 million people were diagnosed with the chickenpox each year, causing 10,000 hospitalizations and 100 deaths each year. In 2007, the American Academy of Pediatrics recommended a second dose be added to the vaccine schedule. Since the implementation of the varicella vaccine program, mortality has decreased by 66%, the incidence has decreased by 90%, and hospitalization rates of varicella have decreased by 80%, proving the vaccine program to be successful. Please see Canvas for our posted discussion, and thank you for watching.